Chairman, ladies and gentlemen, first of all, I would like to thank the organizers and especially Dr. Sparias for their kind invitation. So within the next 10 minutes, I would like to share with you a few thoughts about the singularity of bicuspid aortic valve anatomy, about the available clinical evidence, and the critical knowledge gaps regarding TAVI utilization in bicuspid aortic valve patients. And finally, this presentation aims to offer an integrated framework for understanding the current role of TAVI in this particular subset of patients. Randomized control trials have traditionally excluded patients with bicuspid aortic valve anatomy, which is the most common congenital heart disease occurring in 1 to 2% of the total population and representing about 25% of the patients over 80 who are referred for aortic valve replacement. From our data, 20 out of 160 patients per year who are treated with TAVI, in other words, 12% of our patients have bicuspid aortic valve anatomy. This is the most common and widely accepted classification of bicuspid aortic valve proposed by Sievers, which takes into consideration the numbers of the raphe and the most common types, type 1 with 1 raphe, and the fusion between the left and the right coronary cusp. A novel international consensus is currently available that takes into account 3 parameters: the sinuses, the cusps, and the absence or the presence of raphe. Multiple advantages are related with this new classification. It can depict all various bicuspid aortic valve morphologies. It includes different aortic phenotypes. It includes symmetry assessment, which is very important for the surgical repair planning. And finally, it recognizes rare types of bicuspid aortic valve phenotypes, such as fused bicuspid aortic valve without raphe and 3 Valsalva sinuses. Bicuspid aortic valve is an aortopathy. With regards to the mechanisms of aortic dilatation in bicuspid aortic valve patients, 2 different aspects are there: the hemodynamics and the genetics. Patients with aortic root enlargement have genes that are related with this inherited disease, with fibrillin deficiency and the changes or releases of metalloproteinases resulting in damage of tunica media of aorta. On the other hand, we have hemodynamic changes. We have turbulent flow and increased wall shear stress, which increases the dimensions of the proximal part of the ascending aorta. A registry which followed up closely 600 ambulatory patients with bicuspid aortic valve disease showed that 1/4 of them, 25%, met one of the primary cardiac events, which was the composite of either cardiac death, intervention on the aortic valve or ascending aorta because of aortic dissection or aneurysm, or congestive heart failure requiring hospital admission. 3 risk factors in a multivariate analysis were related with this increased risk of events: the age older than 30 years, moderate or severe AR, moderate or severe AS. Patients with more than 1 risk factor had 65% risk at 10 years to have a primary cardiac event. So the prognosis in this particular subset of patients is not so good, and you have to keep this in mind in early decision making. The largest available registry, which includes, of course, bicuspid aortic valve patients too, is the STS-ACC-TVT registry. This is an analysis of 2,691 propensity score matched pairs of bicuspid and tricuspid aortic stenosis treated with a balloon expandable Sapien 3 valve, showing no difference in all-cause mortality. At 12 months, there was a difference in stroke rates at 30 days, which was minimal at 12 months. And these are the results from the same registry with regards to the self-expanding supraannular valve of Medtronic platform, the Evolut R and Evolut Pro valve, showing no difference in all-cause mortality at 12 months and no difference in stroke rates, again, at 12 months. The BEAT International Collaborative Registry compared patients with balloon expandable and self-expanding valves treated, bicuspid patients treated with TAVI. It's not a randomized controlled trial. It included 242 patients. There was no difference in device success rates, higher rates of paravalvular leak in the self-expanding valve, and better hemodynamics in the groups of self-expanding valve. Similar results from the ad hoc registry, which included 955 patients. No comparison head-to-head between the balloon expandable and self-expanding valves. No difference in technical success rates. Higher rates in pacemaker in the group of self-expanding valve as expected, and more than moderate or greater paravalvular leak in the group of self-expanding valve. A very interesting registry focused on the patients who have excess leaflet calcification and calcification on the raphe, and showed that these two factors increase significantly the risk of complications when both of them are present. So excess leaflet calcification and calcified raphe, then the risk of major adverse cardiovascular events at 2 years is 25%, significantly higher compared to the patients without these two risk factors. And as expected, the paravalvular leak is also higher, and we all know about the significance of paravalvular leak in the long-term prognosis. This is a comparison of patients who are treated with bicuspid anatomy, treated surgically, and with TAVI. It's a registry with propensity score matching with 1,390 patients. The in-hospital death rates were lower in the group of TAVI, while the major adverse cardiovascular events at 30 days and 6 months were similar, without statistically significant difference. And this is the only randomized controlled trial that's available. The Notion 2 trial included 370 patients. 100 of them were patients with bicuspid anatomy. And it's interesting to highlight that in this randomized controlled trial, in bicuspid aortic stenosis, patients who were treated with TAVI, they had worse results with regards to the primary endpoint, which was the death, stroke, and rehospitalization. You have to keep in mind that these were patients, low-risk patients under 75 years old, and we have to emphasize that in this particular subset of patients, younger patients with low risk, the surgical approach is still the best way to go. One important parameter of treatment of the bicuspid aortic valve anatomy is the size selection. Multiple methods have been proposed. Georgiou and his group proposed the analysis based on the Bavard registry, which takes into consideration the anatomy of the annulus and 4 millimeters above the annulus, the intercommissural distance. So we have in 2/3 of the patients not the typical tubular anatomy, but flared or tapered anatomy, and the sizing is based on these findings. Multiple other methods have been proposed, like the LIRA, which is the level of implantation at the raphe. The raphe is the most rigid compartment of the anatomy, and where the valve remains constrained. So it must be taken into account when we measure the annulus. The Casper method, which takes into consideration the calcium score, the raphe length, and the calcium prevalent on the raphe side. And the circle method, which is used mainly in balloon expandable valves. It consists of drawing of circles 3 millimeters above the annulus, and to check if this fulfills the anatomy without risk of annulus rupture. Multiple procedural considerations should be considered. For example, balloon valvuloplasty is highly recommended, especially in self-expanding valves with the smaller size of the annulus. Implantation technique, the transcatheter half valve positioning should be higher than the normal. Balloon post-dilatation carefully, and commissural alignment, as we have to deal with younger patients. The balloon expandable valve used to be implanted a little bit higher in order to prevent any overhanging of the aortic cusps. And here are the complications of TAVI in bicuspid aortic valve anatomy. The paravalvular recalculation is frequent, mainly because of stent undersizing, stent eccentricity, or high calcium score. The aortic root rupture, especially with balloon expandable valve, is an issue. Coronary obstruction, although rare, should be considered as a complication. That's why we have to, the measurements with the CT are very important. Stroke is higher, the rates of stroke, ischemic stroke are higher too, mainly because of the high calcium score. And in these cases, maybe the cerebral embolic protection devices should be used, although we don't have strong data supporting that. Finally, the need of permanent pacemaker implantation in these cases is high. This is a case from our practice, extreme calcification with a raphe between the non-coronary and the right coronary cusp, multiple comorbidities, 81 years old, predilatation with an undersized balloon, self-expanding 23 millimeter FX valve was deployed, and with this result, I think is acceptable. So finally, ladies and gentlemen, dear Chairman, what we know about TAVI in bicuspid aortic valve disease is that it's feasible and safe. 1-year mortality is similar to surgery and tricuspid anatomy. We have improved results with newest generation of transcatheter heart valves. Calcified raphe and extreme leaflet calcification are associated with poor outcomes. What are the warning signs about TAVI in bicuspid aortic valve? Higher risk of stroke than in tricuspid anatomy, higher risk of pacemaker than surgery, higher risk of annulus rupture, especially with a balloon expandable valve, and higher risk of more than mild paravalvular leak than tricuspid anatomy or surgery. And what are the remaining questions? Anatomical features that will guide us about the favor or unfavorable TAVI, the optimal CT scan sizing methods of transcatheter heart valve selection, the type of the valve should be used, the durability, no data about the durability or the risk of valve thrombosis, and finally about the evolution of aortopathy after TAVI. Thank you for your attention.
Thanks a lot, Dr. Georgiou. Excellent presentation. There is time for comment. But first, I would like to invite a cardiac surgeon.